Hello everyone, my name is Leanne White and I'm a clinical facilitator at the Harry Crosley Children's Nursing Development Unit at UCT, and I want to welcome you today to our journal club. Our article today is the assessment of quality of life in children with tracheostomies and their families in a low to middle income country. It was published in the International Journal of Pedaitric Otorhinolaryngology and authored by Din et al. Today's article will be discussed in a podcast generated by Notebook LM. But before you listen to the podcast, I'd just like to introduce the article. It was a research article using a descriptive observational study, which focused on the quality of life of children with tracheostomies and their families in a low to middle income country, specifically South Africa. A descriptive observational study are studies that are conducted without any intervention. In these studies, we purely observe for an outcome. It investigated how families, often from poor socioeconomic backgrounds with limited education, coped with the challenges of caring for a child with a tracheostomy. The study found that despite difficult circumstances, a comprehensive training program, in this case the Breathe Easy program, can empower carers and that socioeconomic factors did not significantly correlate with the overall quality of life scores. However, children with major medical comorbidities had a significantly lower quality of life score, indicating a need for additional support for the subgroup. But listen to the podcast, which will discuss this in a lot more detail. Just to note that in the podcast, the word tracheostomy is abbreviated to trach. They will also discuss monetary value in dollars. Where you hear this dollar amount, just to note, it equates to 10,000 Rand. Sit back, relax, and enjoy the podcast. Once it's finished, we have some questions that we encourage you to have a look at to generate further discussion on this topic.
Imagine this scene for a moment. You're caring for a child with a tracheostomy at home. That's already incredibly complex medical care.
It really is. Demanding.
Now, picture doing that in a place with very few resources.
Yeah.
Maybe low income, maybe limited formal education yourself.
Yeah.
What kind of quality of life is even possible then? For the child, for the family, it almost feels impossible, doesn't it?
That's a profound question. It's where intense medical needs meet the reality of, well, significant socioeconomic challenges, things we often don't face in wealthier settings.
Exactly. And exploring that very question, how is it possible?
Yeah.
That's what this deep dive is all about today. We're digging into a specific study that looked right at this. Families managing pediatric tract care in South Africa, a low to middle income country.
Right.
Our mission here is to pull out what this research tells us. The key insights about resilience, about capacity, maybe where we least expect it.
And the source we're drawing from is a study published in the International Journal of Pedaitric Otorhinolaryngology. It looked specifically at the quality of life for kids with trachs and their families in Cape Town who were part of this program called Breathe Easy.
Breathe Easy.
It's significant because it's really one of the first to look at this in a genuinely resource-limited setting.
Got it. So before we get to the program and the results, let's really unpack the challenge itself. The study introduction makes it clear, living with a pediatric trach is tough anywhere.
Absolutely. The baseline difficulty is high.
We know about the social isolation, the psychological stress, the medical worries, the financial strain. That comes up in studies from, more developed countries all the time.
Yes, parental distress, impact on mental health. These are known burdens associated with this kind of care, regardless of location.
But the contrast between those settings and the setting in this study is pretty stark, right? The source emphasizes that.
It's a night and day difference, really, and crucial to understand.
So paint that picture for us. What kind of support did families in those, say, North American or European studies often have?
Well, the source gives examples. One North American study found 59% of families had daily home nursing.
Daily nurses. Wow.
Yeah, and 11% even had round-the-clock nursing care. Another study mentions 77% had home care for about 11 hours a day.
Okay, so significant professional help in the home.
Definitely. And often the parents or carers in those studies had higher education levels. Like one study noted 64% had undergraduate or graduate degrees.
Right. College educated, often with professional nursing support. That's the backdrop in many developed countries.
That's the typical picture, yes.
Okay, now compare that to the families in this South African study. What were their circumstances?
It's a dramatically different reality. Get this, 85.1% of the primary carers. Their highest education was primary or high school.
85%.
Yeah.
Compared to 64% with university degrees in the other example. Huge difference.
Massive. And that's just education.
What about economically? Living conditions?
Also incredibly challenging.
Yeah.
42% of these families had an annual household income under $675.
Under $700 a year.
For the whole household, yes, often below extreme poverty levels. And nearly a quarter, 24%, lived in informal housing. Shacks, temporary structures, that kind of thing.
So you've got the inherent stress of managing a trachea airway, the suctioning, potential emergencies, and you layer on top extreme poverty, maybe precarious housing, and limited formal education. How does that complex medical need affect those existing struggles?
It just intensifies everything. The home care responsibilities skyrocket. There are indirect costs, even in public systems. And the emotional toll, it's immense.
Yeah.
But one of the most concrete impacts the study highlights is on employment.
Okay.
Before the child needed the tracheostomy, 72% of the main carers were in full-time employment.
72%.
Yeah.
A strong majority working.
Right. Now, after the tracheostomy insertion, that number dropped to only 28%.
Wow. From 72 down to 28%.
And maybe even more telling, 64% said straight out they would be working if they didn't have these caregiving responsibilities.
So it's not just losing income, it's losing the potential to earn altogether. A huge economic sacrifice.
It's a fundamental shift in their lives. Absolutely. Massive sacrifice.
Okay, so the challenges are immense, almost overwhelming, really. How does this Breathe Easy program even start to tackle this? How do they support these families?
So the Breathe Easy program, run out of the Red Cross War Memorial Children's Hospital, is central here. It's been going for over 30 years.
30 years. Okay. It's experienced.
Very. And it's specifically designed to support all kids with trachs, but with a real focus on helping those from poorer backgrounds make that difficult transition from hospital to home.
And what's their approach?
Yeah.
Especially since, as you said, regular home nursing just isn't an option, like in those richer settings.
That's the key, isn't it?
Yeah.
Their model has to work without that. So it's built entirely around intensive in-hospital training for the carers themselves.
Training the family.
Exactly. Empowering the family. It's not about sending nurses out. It's about equipping the parents or whoever the main carer is.
What does that training involve?
It's pretty comprehensive. Understanding breathing, how obstruction happens. Lots of practical hands-on skills practice using dolls, mannequins.
Okay.
They use picture-based instruction booklets, which is smart given the varying literacy levels. There's group counseling. And crucially, lots of intensive one-on-one coaching.
So they really drill down on the practical skills and understanding.
They have to. The goal is making the family confident and competent to be the frontline providers for their own child, even handling emergencies.
How long does this training usually take?
Typically about 4 to 6 weeks while the child is still in the hospital preparing for discharge.
So a significant investment of time before going home.
Yes. And the author stressed this model works because it doesn't depend on home nursing, which just isn't available there. The families have to be ready.
Okay, so that's the program. Intense carer training. Now, how did the study measure the outcome, the quality of life for these families facing all this?
They used a validated tool specifically for this group. It's called the Pediatric Tracheotomy Health Status Instrument, PTHSI for short.
PTHSI.
Got it.
And what does that measure?
It looks at 4 main areas or domains. One is the physical symptoms the child has related to the trach.
All right.
Another is about medical visits, how frequent they are, and the financial impact of those visits. Then there's the overall quality of life of the child, and finally, the quality of life of the carer.
Makes sense. Covering the key aspects.
Right. And higher scores mean better quality of life.
Huh.
They did adapt it slightly. They took out questions about home nursing because, well, it didn't apply here.
Logical.
Yeah.
And who actually participated? How many families?
They had 68 families in the study, all managed through the Breathe Easy program. The children all had their trachs for at least 6 months, so they were settled into home routines.
Huh.
And importantly, this included complex cases, kids with other syndromes, some needing home ventilation. So it reflected the real-world patient population.
Right, so we had the setup, huge challenges, a unique training-focused program, a way to measure quality of life. Let's get to the results. What do they find? This feels like the crucial part.
It really is, and this is where things get, well, quite surprising. The overall average PTHSI score for these families, it was 110.2 out of a possible 150.
110.2 out of 150. What does that mean in percentage terms?
That's 73.5%. And the study authors themselves describe that score as very good.
Very good. Wait, despite the deep poverty, the informal housing, the limited education we talked about, no home nurses, the hit to employment, they scored very good on quality of life.
That's what the data showed. It's pretty remarkable when you consider the context.
Let's break that down. What about the scores in those different domains?
Okay. Physical symptoms scored around 71%. Quality of life for the carer was about 73%.
Okay.
The score for frequency and financial impact of medical visits was incredibly high, almost 95%.
95%. What does that suggest?
It strongly suggests these families were managing things really well at home without needing constant doctor visits or emergency care specifically for the track. They weren't heavily reliant on the healthcare system day to day.
That points to effective home management then. What about the child's QOL score?
That one was lower, around 59%. Still, it contributed to that overall very good average.
Okay, that medical visit score is really striking. But the overall score being very good. How did it connect to those socioeconomic factors? Did income or education or housing type make a difference to the score?
This is probably the most counterintuitive finding of the whole study.
Yeah.
Despite all those challenges, we detailed the low income, the informal housing, the lower levels of formal education for carers. The study found no significant correlation, none.
No significant link between any of those socioeconomic factors and the family's overall quality of life score.
Exactly. Whether a family was earning very little, living in a shack, or the carer had only finished primary school statistically, it didn't predict a lower overall PTHSI score in this cohort.
So the data is basically saying your background circumstances didn't determine how well you coped or your quality of life managing the trach care in this specific context.
That's precisely what the numbers suggest. And the author's interpretation is that this is powerful evidence for the effectiveness of their training model.
The in-hospital training.
Yes. That intensive training seems to have successfully empowered these carers, giving them the skills and the confidence to manage complex care, including emergencies, regardless of their background or education level. It sort of leveled the playing field in a way.
That really challenges the assumption that you need, a certain level of education or income or professional home support to handle this successfully.
It does. It suggests that maybe the training and the support system provided by the program were potent enough to override the expected impact of those socioeconomic factors.
Because in this setting, being able to handle things at home is critical, right? Getting to a hospital quickly might be difficult.
Absolutely. Transport challenges, distance. Empowering the carer to manage things confidently at home, including emergencies, becomes paramount. That skill, that confidence instilled by the training seems to be the decisive factor here.
And didn't you mention the healthcare use data supported that idea of self-sufficiency?
Exactly. Remember those numbers for the 3 months before the survey? 68% didn't need a doctor's visit for the track.
Right. 78% had no emergency visits. 81% had no hospital stays related to the track.
Those are impressive stats for kids with tracks, especially given the setting.
Very impressive. And carers also reported feeling supported. They felt they could get help if needed. And over 60% mentioned extraordinary support from the Breathe Easy team.
Okay, so they felt supported, managed well at home. How did these overall results stack up against studies from those well-resourced centers, like in the U.S., that did have home nursing and maybe higher parental education?
This is another really interesting comparison the authors made. They looked at results from Boston Children's Hospital, a top center, using the same PTHSI instrument.
Okay.
And they found the quality of life scores in their South African group compared favorably. Specifically, the scores for the child's physical symptoms and the carer's quality of life were actually slightly better in the South African cohort.
Wait, hang on. Slightly better scores on some key aspects. In the group with extreme poverty, limited education, no home nurses, compared to families at a leading U.S. hospital with those resources. That's what they found. The child's overall QOL score was comparable, but carer, QOL, and physical symptom scores were slightly higher in the Cape Town group.
That's more than surprising. That almost flips the script on what we think is needed for good outcomes.
It certainly challenges assumptions, doesn't it? The authors are careful. They mention cultural factors, maybe community resilience could play a role.
Yeah.
But they argue strongly that these findings really highlight the power of their specific training and support model. It's strong evidence for the resilience of these families and the program's effectiveness against incredible odds.
Okay, so if socioeconomic status wasn't the main driver of the overall QOL score here, was there anything that did correlate with poorer outcomes? Was any group more vulnerable?
Yes, there was one key factor that did make a significant difference.
What was that?
It wasn't the family's background, but the child's overall medical complexity. Children who had another major medical condition happening at the same time, like a significant neurological issue or a serious cardiac problem.
Comorbidities.
Exactly. Those children had significantly poorer total PTHSI scores compared to kids where the track was more or less the main issue.
Okay, so the added burden of other major health problems did impact quality of life significantly.
Yes, and specifically, it dragged down the score for the child's quality of life domain quite a bit.
That makes intuitive sense. Managing the track is one thing. Managing it alongside, say, severe seizures or complex heart failure is a whole other level of difficulty.
Absolutely. It points to a specific subgroup within the track population that needs even more focused attention and support.
And are comorbidities common in kids needing tracks?
Yes, the study notes that. Many, maybe most, children needing tracheostomies, including in this group, do have other major health issues. So identifying these higher-risk families early, perhaps before discharge, and planning for extra support seems really crucial.
Okay, so let's try and pull this all together. What are the big takeaways from this deep dive into the Breathe Easy study?
Well, first, it confirms that caring for a child with a track definitely puts a heavy burden on families. We saw that clearly with the impact on employment, the economic hardship. That's undeniable.
Right. No minimizing the difficulty.
But the second point is the big surprise. This study gives really compelling evidence that excellent targeted training like the Breathe Easy in Hospital model can truly empower families, even in settings with extreme resource limits, to manage this complex care effectively and achieve a surprisingly high quality of life.
And the implication of that is potentially huge for healthcare decisions, isn't it?
It really is. It strongly suggests that things like a family's income level or the carer's years of schooling or the type of house they live in, maybe these shouldn't automatically be seen as barriers. Barriers to deciding if a track is feasible or if successful home care is possible.
With the right support system, focused on training and empowerment.
Exactly. That seems to be able to overcome many of those perceived limitations, at least in this context.
And a final key point.
While socioeconomics didn't predict the overall outcome, we absolutely need to recognize and provide extra targeted support for those children with major comorbidities and their families. They are the most vulnerable group within this population.
Got it. So what's the author's conclusion on whether this kind of program could work elsewhere?
They're quite optimistic. They believe that effective, reproducible programs like Breathe Easy can work in lots of different healthcare settings, different home environments. And they call for advocacy for policy changes to support similar training-focused, empowering programs in other low- and middle-income countries.
It really is a powerful story about capacity, about resilience, and the difference targeted support can make. Let's just underline that central finding again.
Yeah, the core message is that despite facing what looks like insurmountable socioeconomic hurdles, severe poverty, limited formal education, basic housing, these families, when supported by the Breathe Easy program's training, achieved remarkably good quality of life managing incredibly complex medical care at home.
And that success seems tied directly to the empowerment they got from that training, not necessarily from material resources or things like home nursing.
Precisely. Effective education and support seem to be the key differentiator.
It really does make you stop and think, doesn't it? About overcoming limitations we just assume are fixed. I mean, if families navigating these kinds of extreme challenges can successfully manage this level of care at home, just with the right training and support structure, where else might our assumptions about what people are capable of or what resources are absolutely essential be holding us back?
That's a great question.
What other opportunities are out there to create this kind of fundamental empowerment through really targeted education and support, maybe in totally different fields?
Yeah.
It certainly challenges how we define essential resources for success,
I hope you enjoyed listening to that podcast. Now, to generate some discussion around the topic, ask what was the one takeaway message you got from this article? Have the results of this article made you think differently about your current practice? And is there an aspect of care that you think you could improve on? And how would you go about initiating this? For this journal club, we've used a new format, which we hope you've enjoyed. The podcast was generated using Notebook LM, which is an artificial intelligence tool generated on the 22nd of May 2025. Just to note, it's been assessed and deemed to be accurate reflection of the content of the article, but may not fully reflect the views, intentions, or accuracy of the original authors. Should you wish to refer to or reference the content, it's imperative that you use the original article. Thank you for joining us today for our journal club. I hope you found the article interesting and relevant to your clinical setting. For our next journal club, please look out on our social media platforms. We hope to see you there. Bye.